Thank you, Dr. Lalit. So I think diabetic vitrectomies and endophthalmitis are one of the most difficult surgeries for a vitreoretinal surgeon. I think everybody wants to be very careful because there may be chances of massive hemorrhage and everybody wants to just avoid this massive bleed because it will prevent the visualization and the surgery. So it is like a war and we have to prevent bleeding and formation of retinal breaks. So I always think the best thing is to control the hemorrhage and to just stop whatever you're doing. So because otherwise you will not be able to proceed with the surgery. So with these advanced machines, with the smaller gauge vitrectomies, the surgeries have become really, very quite comfortable right now. The complication rates have reduced and quite complicated cases can be done. The viewing system has become better, illumination has become better. So the results of surgeries have improved, but still I think in diabetic patients, managing a diabetic VR is still a very big challenge. So just coming to my first video, I'll be showing a couple of videos. So with most of the dissection now, I think can be done with 25 gauge vitrectomies, even 27G I've done a few, but I think the tip is too flexible. I'm very comfortable with the 25G vitrectomy system. So you can do all of the dissection with the help of a cutter. You can go directly over it. And we have got such fabulous machines now. So what you can do, you can either cauterize these small bleeders, or you can use a laser probe only. You can do a endophotocoagulation and stop these bleeders. So in this case, there was not a very massive fresh bleed which was happening. So I used the endodiathermy to just cauterize these small bleeds. And for me, if there is no break, I will not use silicone oil in a diabetic patient. I'll just put air or gas if needed. So this was a relatively straightforward case. In this, you can just stop the bleeders with the help of endodiathermy. So what happens once the bleeding is not controlled? Your bimanual approach in diabetic patients is very good. You can aspirate with one and you can do an endophotocoagulation or diathermize the bleeders with the other hand. Other important thing is when you cut the hyaloid, you should always do an outside in approach. That is what I prefer, and come at the optic nerve in the end. That will prevent the chances of severe hemorrhage. So what happens if the bleeding is still not stopping? We have got one foot switch. You can just press it and the pressure increases in the eye. You have to monitor the time. You have to be very careful because the disc in such patients and diabetic patients is compromised. Look at the arterial pulsations, then lower the IOP and recheck for the bleeder. So this is the next step. So if the bleeding is still not controlled despite you're not able to localize the bleeder or you have increased the pressure. So again, after doing a vitrectomy, you can see there is a large frond which is seen in this patient. So most of the dissection again I do with the help of a cutter only. Can everybody please mute? So we can just do a direct dissection with the help of the cutter only. So most of the dissection is done with a 25 gauge cutter. If there are any bleeders which are visualized, you can diathermize them, and you can increase the pressure with the by pressing button.
The admin mute everybody except Bhuvan because a lot of noise is coming.
Thank you, sir. So in this patient, I also did a foveal sparing ILM peeling. So I just increased the bottle height and the hemorrhage could be controlled, and then this is followed by a pan-retinal photocoagulation. So this is another. I would please request everybody so that they can put their. So this is another instrument. This is an aspirating endodiathermy probe, which was developed by Chang et al. and Andrew Chang. This is a very effective technique in which you can just aspirate using the diathermy probe, and then you can also do an endolaser along with it. So it can remove the blood clots, and along with that, you can do a PRP laser. And the second use is you can also cauterize, you can also do an endophotocoagulation of those bleeders. I have not used this, but I think it is a very effective thing. Suppose there is still a persistent bleed which is happening and the media is becoming very hazy. The best thing is you better use valve cannulas or you plug all ports, wait for 2 to 5 minutes. You can also do an air fluid exchange, but if the bleeder is visible, you can also manually press it. So the important thing is you have to clear all hemorrhages. Bleeding may stop. And I think I'm having a lot of disturbance.
Yeah, there's a lot. I think I was checking there's some attending there.
Sir, everyone is muted. I think the hall coordinator has to mute him.
Miss Doshi, are you there? Jinal Doshi.
So I think now it's quiet, so I'll start. So the next important thing is you can just use valve cannulas, plugged all the ports, wait for some time. You can count for about 2 minutes, 120 to 150, the bleeding may stop and then you can proceed. But if still the bleeding is not stopping, the best thing which I use in a lot of cases is PFCL. PFCL causes pressure tamponade. It closes the, tamponades the bleeder, and then you can proceed further with the surgery. So this is another case in which there was massive bleeding during the removal of the removal of the membranes after membrane dissection. The bleeding was coming continuously. So then I put PFCL once to tamponade these bleeders, and then this was followed by the removal of the membrane. So PFCL, it causes a pressure, it stops the bleeding. You can go ahead with the laser during that time. It will also stop the bleeding, and then maybe when you later remove it, the bleeding stops. So now you can see under PFCL, I'm removing this. I'm trying to remove it. There may be a chance of creating this break, but this was a very adherent membrane. I didn't use a bimanual technique. Probably now retrospectively, I think it would have been better, but I could successfully remove it with PFCL. It acts as a third hand. So if a clot is formed, do not try to remove it. It will re-bleed again and again. So again, you put PFCL, try to laser under PFCL. There will be a good laser reaction under PFCL. So don't remove a clot if it is formed. So this is one case in which I did, again, I've cleared all the tractions, and now there is a hemorrhage which is not stopping. So I inserted a PFCL bubble. I'm doing my PRP laser. Now in this, I removed the clot very proudly, but in the end of the surgery, when I did a air fluid exchange, there was again presence of a blood clot at the posterior pole, as you will see. So my important message is, once a clot is formed, even if it is a large clot, I think it is better to leave the clot and not try to remove it again and again, because it will lead to a secondary hemorrhage, which can be much more worse. So these hemorrhages, they will take some time to clear. They'll take 2 to 3 weeks, but I think they'll do fine. The most important thing, I think, is do not create a retinal break. The surgical results will be much more better. So in the end, you can see I removed whole of the clot, but in the end of the surgery, when I did a air fluid exchange, there was again presence of the clot. But I've done my laser. I had just injected gas in this case. So I'm pretty happy. I've done my laser, 360-degree laser. There is a gas. There was some hemorrhage at the posterior pole, and the patient had excellent results. This is another case. This patient had a tabletop severe old chronic TRD. So I have injected a PFCL bubble after doing a vitrectomy. So this thick membrane, which was thick tractional membrane, which was fibrovascular proliferation over the disc. So I have dissected it with the help of a cutter and scissors, and I pulled it with the help of ILN forceps. So I just, luckily for the patient and for me, I managed to remove whole of this membrane over the posterior pole. So again, there was no break created. So I have not put silicone oil in this patient. So once I remove whole of this membrane and the bleeding is controlled with the help of PFCL, I did a 360-degree retinal laser. The center part was elevated. You can see there is this elevation which is present. There's fluid there, so laser was not possible here. But as much laser peripheral till even till the posteriorly and peripheral was possible, I did it. I left this, and this will eventually settle if there is no break over some time. So the important thing here is not to create any break, to stop the bleeders for using PFCL. So this is my last video. This is one case which I always remember. I operated this patient 4 years back. This is a one-eyed patient, and he had the severe fibrovascular proliferation with a thick membrane over the retina. He had lost one eye, and in this eye, the vision was had movements. So I've done a peripheral dissection. I've done a PRP. Now I'm handling this aggressive-looking membrane. It is bleeding continuously. I cauterized some of the vessels, but it was not so helpful. So I injected a PFCL bubble. And this is a technique. Sometimes if I do, I'll just rotate the eye to stop the bleeding, and then I'll rotate the eye again and dissect with the help of a scissors. Normally I use a cutter, but here I was directly over the fovea. I wanted to be extremely careful, and if this patient could get any vision, I would have been really very happy. And by God's grace, things were going fine in this patient, for the patient as well for me. So very gently, all these tractions once removed over the macula, then I went ahead with a cutter and removed all these bridging dissections. I was not very aggressive. I wanted to clear whole of the fovea and relieve the tractions. I didn't want to remove all these membranes. I just trimmed these membranes in the end once all the traction was relieved. So PFCL really helped me to stop the bleeders and going. So after 1 week, this was the fundus picture. And after 1 month, the vision became much more clear. It improved to about 6/12. And this patient was seen in my OPD. He was reading a newspaper after 2 years, and it really gave a lot of satisfaction to me. So if the bleeder is still not localized and it is continuously bleeding, despite all these procedures, I think it is better to close it. Do not do a blind surgery. reoperate the patient after 5 to 7 days. You can give an anti-VEGF at the end of the surgery, although I don't think it will work a lot. They usually wash out very fast. But the important thing, again, I'm stressing, do not create a break. It will lead to retinal detachment, more PVR. The other option which I've done in two patients, I've done this. I've left the eye with PFCL. The patient I had to operate, not given pre-operative anti-VEGF, and it was bleeding so much. So I left PFCL inside the eye, did as much laser as possible, and you can operate after 3 to 5 days. It is not very toxic. It may cause severe inflammation, but I have not seen it. You can operate after 5 days. And there are some publications by Australian authors who have done, they've left PFCL and it really works. They've even used it as a tamponading agent in GRT. So I think PFCL will tamponade the vessel, and then you can operate after 2 to 5 days, remove the PFCL, proceed with your surgery, and use gas, or if there is a break, you can use silicone oil. So the best thing is prevention. Control all the systemic status, control bleeding conditions, the diabetic status, hypertension. There are potential risk factor. Anticoagulant is associated with a higher risk, but there are no serious consequences. It is always better to suspend anticoagulant use, but there is no well-defined study. So it's very important for a good control of the hypertension. Prolonged surgery is usually unfavorable outcome. So again, I'm saying if there is a lot of bleed, it is better you stop the surgery, operate. So anti-VEGF have really been a game changer. I think most of in such complicated cases, it is better to use an anti-VEGF agent and then operate after 3 to 5 days. It has made the surgery much more safer, much more easier, improve the view, and decrease the chances of hemorrhage. So putting it all together, I think these all techniques, every surgeon has got his own approach. But for me, the first technique is better to use a valve cannula system. It will avoid the pressure fluctuations. You can easily increase the pressure. Chandelier light should always be available. I don't use it in every case, but I keep it. If I need it, I will use it. Cut the hyaloid from outside in. I think this is a better approach to avoid severe hemorrhage. If you go straight at the disc and you cause a severe hemorrhage, then you have not even completed your vitrectomy. You can use, you can aspirate with one hand if you're using a chandelier system, with the other hand. So tip number 5, again, use pre-operative anti-VEGF agents in such cases, and it is better to operate within 3 days, maximum 5 days, so that the contraction does not increase. And as I said, do not pull these membranes. They can cause more hemorrhage. It can cause a break. If you cause a break, then things become really messy. So use of PFCLs, I think it is a very helpful thing. I use it quite frequently in diabetic patients if I'm in a problem. It gives a clear media. You can perform a laser under it. You can remove certain membranes under it. And in worst case scenarios, I think it can also be used as a tamponadic agent, and later you can reoperate it. So I sometimes even don't even use gas. I would just like to leave air, and most of the patients do fine if I have not created a break. So thank you very much for listening.